Good afternoon, everybody, and welcome to the Medicine Grand Rounds. It is my honor and pleasure to introduce today's guest speaker, Dr. Ty Gluckman. Dr. Gluckman is currently the Medical Director for Clinical Transformation at the Providence Heart and Vascular Institute in Oregon. He has an extensive interest in quality and clinical transformation improvement projects in several areas, as you're going to hear shortly. He did briefly, without taking time, he graduated did his internal medicine training at Northwestern University Medical School and the McGaw Medical Center, and went on to Johns Hopkins for cardiology training, where he worked for a few years and then subsequently moved to Portland for the current position. He, like I said, has an extremely strong interest in implementing cardiovascular care improvement strategies. He's published extensively several articles and chapters. He's also an associate editor for the practice guidelines and the clinical documents for American College of Cardiology.org, while also being on the interprofessional practice track at the National Cardiovascular Data Registry, which is our NCDR annual meeting that happens. He has also helped build several apps for your atherosclerotic ASCVD risk calculators and stuff, and won awards for making these apps as the best app in 2014, from what I gather. So I would actually let Dr. Gluckman introduce himself far more than I'm going to do here, and let you hear from him.
Awesome. Welcome. Thank you. Thank you for the kind introduction. I'll be the first to say, though, I actually was involved in the design and built out the whole app, but I didn't actually do the coding. You don't want me doing coding. Can everybody hear me in the back okay? Volume's okay? Great. Again, my name is Ty Gluckman. It's a real pleasure to be asked to join you all today. And for the next roughly 45 minutes, excuse me, to 50 minutes, my goal is to actually, broadly speaking, talk about updating cholesterol management. There is a focus on PCSK9 inhibitors, and we'll talk about that as a newer drug class, not so new, since we're approaching 4 years since they were approved. Many of you may have seen that just on Sunday, the new prevention guidelines, primary prevention guidelines, were just released. Blood cholesterol guidelines were just released in November of this past year. We had a fun panel just a few days ago related to the cholesterol guidelines and their implementation. So hopefully this will be entertaining for you. My hope will be there to be time for questions as well. As many of you may know, and some of you who are in training may not need to do this for the purposes of this is just my background. We'd asked people to sign in when they came in, and this activity is independent, but it's sponsored by Amgen, Sanofi, and Regeneron. And in the packet in front of you should be the slides, so you shouldn't have to be feverishly writing stuff down. Maybe you don't want to feverishly write down anything, but if you wanted to, the stuff that should all be there for you. But I would ask that for those of you who will be wanting CME credit, there is a pre-activity survey. If you could please fill that out, and then similarly, there's a post-activity survey and evaluation. And the reason is, at the end of this, was Ty's information helpful? Did it change what I'm going to be doing? Or did I not learn anything? Those things are very helpful for us to be able to understand how to be able to gauge future education. I'm not going to read through these learning objectives because I think it roughly revolves around understanding changes in lipid management, and I'll do my best to run through them as we go through the slides today. So I always think it's helpful to start with a patient case. It's hard to not come to a medical school in an academic setting and not present a case. So this is LR. This is a patient, or this is not my patient, but it's like someone I could see every day. 69-year-old man presents to the emergency department with 1.5 hours of stuttering, precordial chest pain, and shortness of breath and nausea. I'm a cardiologist, so this is not a diagnostic dilemma. And he reports that these symptoms are different, however, from that which he experienced with a prior myocardial infarction. He has all of the risk factors you would normally expect: hypertension, hypercholesterolemia, type 2 diabetes, and coronary artery disease. And 3.5 years ago, he had a myocardial infarction treated with percutaneous coronary intervention of his left anterior descending artery. He also has reflux disease and osteoarthritis. He's on low-dose aspirin, simvastatin at 40 milligrams each evening, a combination of an ACE inhibitor and a thiazide diuretic, a PPI, a beta blocker, and he takes occasional non-steroidal in the form of ibuprofen. He has a 29-pack-year history of smoking. He quit in 2015 at the time of his myocardial infarction. Great job. Social, alcohol use, and no illicit drug use. And he notes, though, that he's had limiting symptoms, in this case myalgias, with atorvastatin and rosuvastatin in the past, thus the rationale for why he is taking simvastatin currently. And just for vernacular, the current in vogue terminology now are statin-associated muscle symptoms, which is a broad vernacular, or SAMS, for a spectrum of different symptoms that can fall under that, including myalgias. His mother experienced a transient ischemic attack at age 63. On physical exam, fairly unrevealing other than being obese from a body mass index standpoint, mildly tachycardic and hypertensive, although this is in the setting of precordial chest pain overall. ECG shows normal rate and rhythm, but has new downsloping ST segment depression in the inferolateral leads. His creatinine is 1.3. He's got a peak troponin I of 7.92, and his lipids are shown here, including a LDL of 129, HDL of 38, and an Lp(a) of 90 nanomoles per liter. Hospital course, again, I'm really cutting to the chase here, but he's diagnosed with a type 1 non-ST segment elevation myocardial infarction, is treated with IV fraction heparin, 324 milligrams of aspirin, metoprolol succinate, all in the emergency department, goes to the cath lab and has a new, since the last angiogram 3.5 years ago, 95% stenosis with thrombus that's treated with a drug-eluting stent. So in the context of this case, hopefully all of you, because I do, ask a lot of questions. And anytime I'm presented with a case, there are a lot of questions we should all be asking. Is the person getting the right therapy? Are there things that I would have done differently? So in this case, is the patient being treated with guideline recommended LDL cholesterol lowering therapy? If the answer is yes, maybe we go home, we end there, you guys can enjoy your lunch without a talk. But the answer, of course, is no, at least in this case. And are there changes that are invited for this patient? And if so, what might those be? And then finally, what are barriers to potentially intensifying this patient's treatment regimen overall? So this may not project as well from the very, very back. But in November of 2018, the new blood cholesterol guidelines came out. And for those of you who recall previously, we had 2013 blood cholesterol guidelines. Those were the previous iteration. And they essentially fundamentally defined 4 key groups. A, do you have atherosclerotic cardiovascular disease? Have you had a heart attack? Have you had a stroke? Have you had bypass surgery? Have you had angioplasty? Do you have symptomatic PAD? Have you had an abdominal aortic aneurysm? Those types of conditions. And if the answer is yes, that's one group. If the answer is no, the next question is, do you have severe hypercholesterolemia, which helps to define, in many cases, people with familial hypercholesterolemia. And this is defined as an LDL cholesterol greater or equal to 190. The answer is yes. Go down a different path. If the answer is no, do you have diabetes? And then finally, if the answer to that is no, you're then in a primary prevention group. And it's beyond the scope today to talk, unfortunately, about all the different groups. We could be here for hours. I promise we won't. But I'm going to focus in on the highest risk groups, and particularly the ASCVD group today overall. And interestingly, in 2013, we treated atherosclerotic cardiovascular disease as one homogeneous condition. Now, I don't know anybody would have said it's a homogeneous condition, but if you had a heart attack 3 weeks ago or you had a heart attack 6 years ago, you were put in the same bucket. If you've had a heart attack and have diabetes, polyvascular disease, you have multivessel coronary disease, you were put in the same bucket as somebody who had a single lesion and had stable ischemic heart disease and had never had an MI. And so the guidelines in November, this past November, changed to try and get at the notion of not all people with atherosclerotic cardiovascular disease are the same, and they divided these individuals fundamentally into 2 broad groups. Those defined as being at very high risk with atherosclerotic cardiovascular disease, and by definition, those who are not at very high risk with atherosclerotic cardiovascular disease. And to be clear, everybody's high risk. It's just, can we define a subgroup who's particularly at heightened risk above and beyond? So what defines people as being at very high risk? These are individuals who have had either 2 of the major ASCVD events, 2 or more of these listed up here: recent acute coronary syndrome, unstable angina, non-STEMI, STEMI, history of a myocardial infarction other than that within the last 12 months, history of ischemic stroke, or symptomatic PAD, or one of these plus two or more of the things below, and that probably is a more common scenario where someone's had a prior MI, but they're 66 years of age and they have hypertension, as an example. That puts them in a very high-risk category overall. And although these shouldn't be always thought of as numerically, they're all the same, nonetheless, as you stack more of these things in the bottom, and certainly more of these things at the top, you are stacking your risk and are even at that much of a heightened risk overall. So what do we do for people that have atherosclerotic cardiovascular disease, regardless of whether they're at very high risk or not very high risk? And if you take nothing away from today's presentation, the answers numbers 1 through 10 is statins, and in particular, high-intensity statins. And there may be people sitting in the audience who says, this is nothing new, we've been talking about this for 20 years, but I'll show you some data that at least calls into question, if it's not new, why do we have gaps in care that we do today? So this is a distribution on the x-axis of LDL cholesterol achieved, in this case, mostly in placebo-controlled, but some active controlled trials, higher versus less intensive statin regimens. And as you can see here on the y-axis, the event rate. And the takeaway from this is as you pharmacologically, with statin therapy, lower one's LDL cholesterol, it's associated with a reduction in the rate of adverse cardiovascular events. Not surprising. And the only thing I would say is if we had a superimposed curve for primary prevention, it looks very similar, except it's a more shallow slope, such that you need to achieve a greater magnitude of LDL cholesterol reduction to achieve the same level of event reduction, or put a different way, for a given level of LDL cholesterol reduction, you don't get the same magnitude of event reduction overall. So Tom Maddox, who's a good friend of mine, published this article in JACC in 2014, and it comes from the PINNACLE registry, which is now the world's largest ambulatory longitudinal cardiovascular registry with over 10 million patient encounters. And of those people who participate in enrolling in PINNACLE, about 80% are cardiologists. This is one of my embarrassing moments as a cardiologist, a part of a community. When you look at the data, this is a snapshot of all different groups of individuals, but I'm going to have you focus in on the million individuals with atherosclerotic cardiovascular disease. We didn't have 10 million patient encounters at that time. These are individual patients. And what you can see here is color coding to corresponding patterns of what people are doing in terms of lipid-modifying therapy. And in the United States, largely managed by cardiologists, 28% of patients are on no lipid-lowering therapy. Let me repeat that again. 28% of people are on no lipid-lowering therapy, 3% are on a non-statin. So fully, 30+% of people in the United States managed as of 2014 were receiving no statin therapy, in spite of the fact that there are 7 agents, 6 of which are generic, and it's the mainstay for more than 2 decades in terms of our evidence of the therapies with a substantial evidence base to reduce rates of events. Now, I'll also say that I don't believe that most cardiologists don't know that statins are beneficial. I will tell you what a lot of us interact with and deal with patients. A patient comes in and says, my Aunt Bertha was intolerant of statins, thus I'm related to Aunt Bertha. I must be intolerant of statins, or I don't want to go on it. Or someone on television says it causes dementia. It doesn't. Someone on television said it causes cancer. It doesn't. But those are the things that you hear, and I would say what's a challenge is many times it takes time to debunk those myths, talk about the value of statin therapy, and perhaps these people didn't want to spend the time doing it overall. There are a small percentage of people who are truly statin intolerant. That number is probably around 1 to 1.5% total of the population. So remember we talked about the fact that this patient was on simvastatin, 40 milligrams a day, which constitutes what's referred to as moderate intensity statin therapy. On average, it will achieve about a 30 to 49% reduction, all comer, that's the average response, to a moderate intensity statin. And it's only because this individual was intolerant previously of both atorvastatin and rosuvastatin. So the question is, what should you do based on this? And in this situation, you decide to add ezetimibe to the patient's regimen, and you check a follow-up lipid panel 8 weeks later, and it demonstrates the following findings overall. Of note, their LDL cholesterol is 101 milligrams per deciliter, and what, if any, change to this patient's lipid-lowering therapy is warranted. As may not have projected earlier on the slide, current evidence, and we can debate whether this is right or wrong, would argue that getting one's LDL cholesterol reduced from baseline by at least 50% is goal number one, and a secondary goal is to get their LDL cholesterol less than 70 milligrams per deciliter in general. So the first thing that was stated in this is you decide to check a repeat lipid panel. And this may sound silly by saying that repeat lipid testing is always recommended, but there were a number of cardiologists, primary care providers who read the 2013 guidelines and said, this is awesome. Put them on a high-intensity statin, set it and forget it. I never need to check a lipid panel ever again. And that's not what the guidelines said at that time, and it's not what the guidelines said in 2018. So in someone in whom you are initiating de novo statin or any form of lipid-modifying therapy or changing their therapeutic regimen, the recommendation is to assess their lipids 4 to 12 weeks later. Why? So other than to check up on them, when we talk about certain therapies like high-intensity statin therapy, which in general achieves a 50% reduction in LDL cholesterol, moderate intensity statin therapy in general has a 30 to 49% reduction in LDL cholesterol, you don't know what magnitude of LDL cholesterol reduction they're going to achieve until you reassess them. And the numbers that are quoted are the mean treatment effect. It's average. Now we know not everybody's average, and there's a bell-shaped distribution of response. Some people with high-intensity statin therapy, where the average reduction in LDL cholesterol is 50%, will achieve a 70 or 80% reduction. Some people will have a 15 or 20% reduction. So the initial check is to ask the question, were they average? Were they a hyper-responder or a hypo-responder overall? And then finally, once people are on a stable regimen, the recommendation is to recheck their lipids every 3 to 12 months, primarily to assess adherence. And some people ask the question, why? And I can tell you, having been on Epic doing my in-basket before we started today, you'll see someone who has a history of coronary disease. Their LDL cholesterol is 48, 52, 64, 56, and then it's 101. And you're like, I bet they stopped their statin. And so it is an opportunity to gauge whether or not someone is compliant with statin therapy overall. So the question that comes up often is if some lowering is good, is more or better overall? And I would say when all of us in this room, short of somebody in this room having familial hypercholesterolemia, when we were born, if our umbilical vein blood was sampled, our LDL cholesterol was around 30, 35 milligrams per deciliter. There are very few isolated hunter-gatherer populations in the world, but when you actually draw their blood, their LDL cholesterol rarely exceeds 40 milligrams per deciliter. So I would argue we have devolved rather than evolved, and some people jump for joy when their LDL cholesterol is 95, which isn't bad from a population standpoint, but it's almost 3 times higher than what we were born with, suggesting the adverse impact largely of environment, diet, and our lifestyle, or lack thereof, that we've adopted over the course of our lifetime. So in general, the question then is, if we were born there, does getting back there pharmacologically provide benefit overall? So this is a pooled analysis of 38,000 individuals treated with statin therapy. On the left side, what you're seeing is the LDL cholesterol and the hazard ratio. In this case, similar to the previous one, but I've inverted the different axes here. And then on the right side, you'll see in orange major coronary events, in blue major cardiovascular events. And what you see is, using this as a reference point of greater than or equal to 175, as you stepwise pharmacologically and get their LDL cholesterol down, it's associated with a point estimate that is trending down towards lower rates of adverse events. On the right-hand side, it's just to reinforce that while statin therapy is beneficial in reducing the risk of peripheral vascular events and cerebrovascular events, the lion's share of the events that are reduced, at least in this analysis, are coronary events compared to the other types of vascular beds. So in 2018, the questions that were raised is, what do you do for people who have very high risk, and what do you do for people who are not very high risk? So for the not very high risk group of individuals, they made an argument that it may be reasonable to add ezetimibe to those on maximally tolerated statin therapy with an LDL cholesterol greater than or equal to 70 milligrams per deciliter. We did that in this patient overall. But this patient just had an acute coronary syndrome, had an MI 3.5 years earlier. Right there, two major factors that put them in a very high-risk category. And so the guidelines just published in November will say it is reasonable to add ezetimibe to those on maximally tolerated statin therapy with an LDL cholesterol, should say greater than or equal to 70 milligrams per deciliter. And that's what we did in this case overall in this very high-risk patient. It also goes on to say it's reasonable to add a PCSK9 inhibitor after having a clinician-patient discussion to those on maximally tolerated statin therapy with an LDL greater than or equal to 70 or a non-HDL cholesterol greater than 100. And the recommendation is that the PCSK9 inhibitor, in terms of sequencing, should follow the timing after you've initiated ezetimibe. Just so you all know, there are other guidelines out there that do exist. These are the 2017 American Association of Clinical Endocrinologists, or AACE guidelines, who, based on some of those stepwise point estimates, even in those with diabetes in extreme risk, are now recommending even lower LDL cholesterol levels, in this case less than 55. But the theme that I want you to take away from this slide more than the number is, as you go up in risk, we are becoming more aggressive in our LDL cholesterol goals. We want to match the intensity of our intervention to the baseline risk of the individual overall. In 2016 and 2017, this expert consensus decision pathway came out that was published by the AACE overall, identifying these 4 statin groups, reinforcing what one should be doing all the while you're considering initiation of pharmacologic therapy, what may be used on top of statin therapy overall. And the bottom line was, all patients with ASCVD, the principal goal is to get their LDL cholesterol reduced by greater than or equal to 50%. So that patient who comes in today with an MI, who you cath and stent, who has an LDL cholesterol of 66 at baseline, the goal is to get their LDL reduced by 50%. So doesn't matter what your baseline LDL cholesterol level is, you are trying to get them down significantly overall. And if secondarily, you get their LDL down by 50% and their LDL persists in being greater than or equal to 70, you can consider additional therapies overall. What is the rationale for using adjunctive non-statin therapy? This is the IMPROVE-IT trial. 18,000 patients with an acute coronary syndrome randomized to simvastatin 40 milligrams each evening, what our patient happened to be on, or the addition of ezetimibe to simvastatin for 7 years. And there was an approximate 20% reduction in LDL cholesterol, and this led to a small, in this case, 6.5% relative risk reduction in the rate of adverse events. What's not shown on the screen, though, is there have been some elegant subgroup analyses from the IMPROVE-IT trial, and when you begin to even further, in an acute coronary syndrome population, look at diabetics, those with polyvascular disease, those with multivessel coronary disease, the magnitude of the benefit widens. You get more and more benefit as you stack risk factors, heighten risk, greater benefit from more intensive LDL cholesterol lowering. So I'm going to pivot now for most of the remainder about PCSK9 inhibitors, and it's a really fascinating tale of how you can discover something and bring a drug to market, in this case, in just over a decade. So I was fortunate when I was at Hopkins, we were one of the sites that did a lot of analyses for what's called the ERIC database, and it's 4 populations that are geographically disparate that, and these are the true heroes out there, these individuals, community-based individuals, swab their cheek and give genetic material, have regular blood draws, fill out surveys multiple times per year to understand in an observational fashion what we should be doing and what we shouldn't be doing in terms of care overall. And there's a really fascinating observation, and I'll cut to the chase because it's a longer story, but I'll try and make it more fun as a shorter story, was there is normally a bell-shaped distribution of LDL cholesterol out there, and they found in particular amongst African Americans, and to a lesser degree Caucasian individuals, there was a group of individuals that had their LDL cholesterol skewed way to the left, much, much lower. And it turns out that these individuals had or were born with a loss-of-function mutation in a protein called PCSK9. And PCSK9 is involved and discovered only in the last 15 years, really closer to 13 years. It's a protein that's involved in regulation of the internalization of the LDL receptor and forms a complex with both the LDL receptor and LDL cholesterol. And so over time, it was discovered that these individuals had an inborn error in metabolism, a genetic mutation that was protective for them. Lo and behold, in an observational fashion, these individuals had about a 90% relative reduction in the rate of adverse cardiovascular events. And so someone far smarter than me said, people out there who are born with a genetic mutation derive this benefit. What if we can create that genetic mutation? Well, they didn't go that far. But what they did was they created a monoclonal antibody that would bind to circulating PCSK9 to essentially inactivate it in an analogous way to a person who's born with a non-functioning PCSK9 overall. And that's what the PCSK9 inhibitors are. And these are therapies that can lower LDL cholesterol by 55%, total cholesterol. They can increase HDL cholesterol to modest degrees, lower ApoB, and interestingly also lower Lp(a) by upwards of 30%. Of note, and I just put this in there, monoclonal antibodies. For those of you who are studying immunology, you probably know this far better than I do. But the two monoclonal antibodies that exist are fully human monoclonal antibodies. And the reason I bring this up is there are two FDA-approved agents that fall in this class. There was one that underwent evaluation that was a humanized but not fully human monoclonal antibody. And what you do over time, if you don't have a fully human monoclonal antibody, is you make antibodies to the antibody. And so you have anti-antibody antibodies, and they will essentially attenuate the effect of those antibodies over time. These two drugs that are currently FDA approved include alirocumab and evolocumab. Both were approved in mid-2015, and they've both been studied in two large outcomes trials. And I will spare you the essentially 6 to 7 years of randomized trials evaluating them in broad populations. At the end of the day, if they effectively lower LDL cholesterol, do they actually translate into event reduction, reduction in adverse cardiovascular events? And that was really important for those of us to prescribe any agent to make numbers look better if it doesn't reduce events isn't worth using overall. So alirocumab was studied in the Odyssey outcomes trial, 19,000 individuals, 1 to 12 months post-acute coronary syndrome. Almost all the patients were on high-intensity statin therapy with an LDL greater than or equal to 70, looking at this endpoint. Fourier evaluated evolocumab, almost 28,000 individuals with stable atherosclerotic cardiovascular disease, 70% on high intensity, 30% moderate intensity statin therapy, similar design with a similar-ish endpoint overall. So this is Odyssey outcomes. This is evaluating alirocumab 4 weeks to 12 months after an acute coronary syndrome. And in this case, treatment with, and these are injectable agents, and I apologize for not mentioning, these are injectable agents that are dosed either every 2 to 4 weeks. You see a significant 63, 61, and then 55% reduction in LDL cholesterol over the course of this duration of out to 4 years, as published in New England Journal of Medicine this past year. This is the principal endpoint for the trial, composite of coronary heart disease death, non-fatal heart attack, non-fatal stroke, or hospitalization for unstable angina. Curves separate just prior to 1 year and give the appearance of continued separation, favoring alirocumab overall. Of note, the greatest magnitude of benefit and what drove that primary efficacy endpoint were people who had a baseline LDL cholesterol greater than or equal to 100, and that shouldn't surprise you overall. Lipids, hypertension, diabetes is all about area under the curve. It is about how bad or dysregulated that level is and the duration of exposure to it. So people who are born with homozygous familial hypercholesterolemia who develop heart attacks in their 20s and 30s, they have LDL cholesterol levels, let's say, of 400, 500 milligrams per deciliter. It only takes them 2 decades, 3 decades to develop those events. People with heterozygous familial hypercholesterolemia, lower levels of LDL cholesterol, but still severely elevated, they need a longer time of exposure because their LDL is not as elevated as the homozygotes. And for all of us who are not heterozygotes or homozygotes, yes, other things will affect it, the presence of diabetes, tobacco use, hypertension, family history, but in general, it's a longer time horizon because you need a longer duration of exposure, area under the curve, because the elevation is not as great. And so people who are further away from their LDL cholesterol goal, not surprisingly, have the greatest magnitude of benefit overall. In this trial, the benefit was a composite reduction in that quadruple endpoint, as shown here, but it also resulted in a significant reduction in non-fatal heart attack, ischemic stroke, unstable angina. The composite of the so-called triple endpoint of cardiovascular death, non-fatal heart attack, and non-fatal stroke was significantly reduced. And interestingly, there was an all-cause mortality benefit. It's what's referred to as a nominal p-value, because when you submit to the FDA, you have to have a very clear pecking order, in which case everything can be evaluated. And they only were able to claim all-cause mortality if there was a reduction in cardiovascular death, which didn't meet a statistically significant p-value. The great thing about these drugs is that they're really well tolerated. These are the frequency of adverse events between placebo and alirocumab, and they're almost superimposable on top of one another. The only thing where we see a heightened risk in alirocumab compared to placebo is predominantly in injection site reactions, which are local mild erythema or discomfort at the site of injection. FOURIER trial. FOURIER trial, again, almost 28,000 people with stable atherosclerotic cardiovascular disease randomized to evolocumab versus placebo. Pretty impressive. These are weeks here, so abrupt drop in LDL cholesterol persisting over time. And this translated into a 2% absolute risk reduction in this quintuple primary endpoint for the FOURIER trial. And this is the so-called triple endpoint of cardiovascular death, non-fatal heart attack, and non-fatal stroke, where there's a 2% absolute risk reduction with separation just around 6 months between the two curves, favoring the use of the PCSK9 inhibitor. This is what's referred to as a landmark analysis, and across medicine you see this increasingly being used. And it's sort of a way of trying to figure out if there are early, very early, or later effects overall. So this analysis took all of the events that took place in the FOURIER trial. In this case, I'm showing fatal or non-fatal heart attack or stroke. And what you do is you see the first 12 months. If I go back for 1 second, remember I'm showing you curves out to 36 months. So what they do is they look at the events out to 12 months, in this case, a 19% relative risk reduction that's statistically significant. And then, short of someone dying, if they're alive, they censor out all of the events and they start the clock over again. And they ask the question from day 366 on, what do the curves look like? And what this shows is, within the first year, there's a significant reduction in events. And then beyond 1 year, there's a significant reduction in events. So it gives you sort of a temporal relationship between which the intervention is either providing or not providing benefit. Remember that many of the trials that we had shown previously got people's LDL cholesterol maybe down into the 50s. So this was the first trial to essentially achieve, on treatment with evolocumab, the LDL cholesterol levels that most of us were born with. So in the trial, these are the 4 quartiles of LDL cholesterol achieved in the evolocumab arm. These are the 4 for the placebo. The mean LDL cholesterol on treatment with evolocumab was 30 milligrams per deciliter overall. So by far the lowest achieved LDL cholesterol. In this trial, no difference in adverse events across the board other than a slightly increased risk of injection site reactions. So this is one of the most, this is hypothesis generating, but this is one of the coolest analyses that we've seen in a long time. So one more thing just to put in your memory bank, and it should stimulate interest, but it shouldn't drive you necessarily to automatically go crazy in this direction, is this was an analysis in the FOURIER trial of the 27,500, half got evolocumab, and of those half 13,700 patients, 500 patients got an LDL cholesterol less than 10. I'll say it again, they got an LDL cholesterol less than 10. And they compared those people to people who had the highest LDL cholesterol of 100. People who got their LDL cholesterol less than 10 in blue had the lowest rate of adverse events in the entire trial and no difference in safety whatsoever. Now there's got to be more than one person in the audience who's like, I remember back to biochemistry, cholesterol's involved in cellular synthesis, involved in the walls of cells. This doesn't make any sense. This must be harmful. And the reality is we don't need cholesterol, particularly LDL cholesterol, in our bloodstream. We do need it for cellular synthesis, but and for hormone biosynthesis and other things, but we don't need it in our bloodstream. And in fact, going back to that ERIC database, those people who had PCSK9 loss of function mutations, their LDL cholesterol is 0, 1, 2 milligrams per deciliter. It's almost undetectable. And they live free of atherosclerosis. So the bottom line is, when we're born, that's probably the highest LDL cholesterol you need in your lifespan, and we are just exposing day after day, week after week, month after month, year after year, our vasculature to stuff that we frankly don't need overall. Now, this doesn't mean use a PCSK9 inhibitor to get a patient's LDL cholesterol less than 10. But what does that mean? If I have a patient, and the one caveat, if they've had a history of intracranial hemorrhage, I don't do this. But absent that, Mrs. Smith, fictitious Mrs. Smith, but she's all too real to me, and she comes in with an MI, and her baseline LDL cholesterol is 70. And she's a hyper-responder to high-intensity statin therapy, and I come back and her LDL cholesterol on repeat check is 11. I don't back off. I don't stop her therapy, assuming she's tolerated. If she's not tolerated, that's a whole separate discussion, but if she's tolerated, I don't back off. I'm not adding ezetamide. I'm not adding a PCSK9 inhibitor, but the point is that the point of backing off, I mean, I get primary care doctors who tell me, they're like, so, Tom's LDL cholesterol is 52, and I'm like, that's phenomenal, that's great. Or his LDL cholesterol is 37, I'm like, great, leave it alone. So if they're tolerating therapy, they should be on maximally tolerated statin therapy, preferably high-intensity statin therapy. If their LDL persists above 70, you need more work to do. If they didn't get a 50% reduction, you need more work to do. But if they achieve very low levels and they tolerate it, not an issue. One last thing, and this was discussed earlier, Mark Banaka is doing an amazing bit of work. He's now at Colorado and left the TIMI group. But it highlights the fact that stacking risk factors really accentuates your risk. So this is FOURIER. This is that population with stable atherosclerotic cardiovascular disease randomized to evolocumab, PCSK9 inhibitor versus placebo on a background of intensive statin therapy. Blue here is showing evolocumab, both of them. Red is showing placebo. And these are people in the solid bar that have stable atherosclerotic cardiovascular disease, most commonly coronary disease, but they also have PAD. Compare that to people who have no PAD. And what's the first thing you note? Doesn't matter which therapy you get. If you have PAD, you have worse events, higher event rates, regardless of what therapy you get. And if you get a PCSK9 inhibitor, your absolute risk reduction has gone from 1.4% with no PAD to 3.5% with PAD. Absolute risk reduction divided, if you take the absolute risk reduction that you have and you divide it into 100, you get the number needed to treat. Higher the absolute risk reduction, the fewer the people that you have to treat in order to reduce one event overall. And so in this side here, he's not doing PAD, but they're looking at hsCRP, a marker of inflammation. And lo and behold, not surprisingly, we know that for people with hsCRPs greater than or equal to 2, these people are at heightened risk. And so they have individuals of less than 1, 1 to 3, greater than 3. And in this situation, you see, not only do you see in all the groups a gradation of risk, but the absolute difference in events between the two arms widens, so you get more bang for your buck the greater the risk of the individual overall. This is a complicated slide, and I don't mean to belabor this. This is Jennifer Robinson from Iowa, but she's essentially saying, can we divide people who may have ASCVD into really, really high-risk groups versus not as high-risk groups? This was published in 2016, but this formed the basis in part for those 2018 guidelines to say, not very high risk, very high risk. And I would say there's a group of us at the college, the American College of Cardiology, are in the process of potentially drafting a document that would begin to sort of segment people even more than just a binary yes versus no for that very high-risk group to better inform perhaps health insurance design. If you were smart, you'd give all the therapies to those people who have the highest risk. They're most likely to benefit from them. They have the most cost-effective, it's most cost-effective to use it in those highest-risk individuals. Skip through a couple of these really quickly. So I will say that the biggest barrier today, other than being injectable, which I don't think is a huge issue for most patients, for the PCSK9 inhibitors is cost. When these were first released, cash pay price, hopefully most people aren't cash pay, but we recognize that a lot are, was around $14,500 a year for the drug. Both drugs are now under $6,000 a year, which I would still argue is very, very, very expensive. If you're a commercial pay patient, much more affordable than if you're a Medicare or Medicaid patient overall. And it's the same that we struggle with whether you're talking about sacubitril, valsartan for heart failure, SGLT2 inhibitors or GLP-1 receptor agonists. For diabetics at increased cardiovascular risk, PCSK9 inhibitors, we are struggling with how do we get new pharmacotherapies, and if I could find a way with pharma to do it, I would. How do we get these to be made available more easily overall? The guidelines did produce most recently a nice schematic. It's a little difficult to read and it may be easier in your book, just highlighting that the incremental cost effectiveness per quality adjusted life year saved and defining what that cut point is would require substantial discounts to the prior pricing. And actually, just concurrent with the publication of this, we saw significant reductions in the prices of those drugs. I think that there's still room to move further in making these more affordable for most individuals. I'm going to skip through that one for a second. So you add ezetimibe to the simvastatin. You do that follow-up lipid profile. We asked about what, if any, change is warranted. Remember, the top portion we had already seen, and this person still has an LDL cholesterol of 101. This was the group that derived the most benefit from alirocumab in the Odyssey Outcomes trial. Their LDL cholesterol is still greater than 70 milligrams per deciliter. So you prescribe a PCSK9 inhibitor, but you're notified that your prior authorization that you submitted is denied. So just briefly, some practical issues. And one could argue that these are practical issues for all therapies that require prior authorization in general. Before we go into that, alirocumab and evolocumab, we've included the indications for these drugs, how they're dosed, how they're supplied, and most common side effects. And the most common side effects should not surprise you. I always get in this debate with my family members when they get their flu shots because they said, I got the flu, and I said, no, you had a reaction to a vaccine, you didn't get the flu, we're not giving you the flu, but what you often will see with antibodies that you're given that you can develop an antibody to is nasopharyngitis, a reaction or soreness at the injection site. Those are the typical things you would see when you might be administering an antibody. So this is an interesting analysis by Seth Baum that was previously presented that took 44,000 prescriptions of PCSK9 inhibitors. When these things were first approved, in their analysis, 83% were rejected outright, 57% were rejected ultimately, but approval was more likely amongst those on high-intensity statin therapy to ezetimibe. Similar thing seen here as well, and obviously a concerning thing is when you see a third of prescriptions abandoned at the pharmacy, the sticker shock of the medications overall. But it highlights what we're going to show in just a minute here is documentation is of preeminent importance. And for those of you who haven't had the luxury of navigating with payers, it's really important. And I understand where they come from. They want to make sure that expensive therapies are in the hands of people, they're being received by patients and being given to those that are most likely to derive the greatest benefit from them overall. So common reasons for denial of a PCSK9 inhibitor are listed here. Number one, failure to clearly document what the indication is. And these may sound like logical things that you would do. We're all busy, but if your documentation isn't complete, you can find yourself dealing with appeal after appeal after appeal overall. Failure to document the specifics of their atherosclerotic cardiovascular disease. For those that you have questions about familial hypercholesterolemia, most patients these days don't get genotyped, but there is something called the Dutch Lipid Clinic Network score. You can Google it. It's a scoring system that allows you to plug in several factors and determine whether they have definite, probable, or possible FH overall. And so for your FH patients, really important to include this or a corresponding other scoring system for FH probability. Failure to submit office notes or labs. So obviously, this is one of the things that payers are going to want to see. Recommendations around lifestyle. For those that have been labeled as statin intolerant, there's a really elegant study that came out a few years ago that showed of patients labeled with statin intolerance, about 93 to 94% of them can be put on a statin. They may be on a low-intensity statin. They could be on a statin twice a week or 3 times a week. But most patients with statin intolerance can actually get on one of the 7 FDA-approved statins today. So these are some of the tips. This is from Tiffany Kaufman, who's at the University in Oregon, who had come up with a number of recommendations to increase the likelihood, specify the diagnosis, be complete in your documentation, include a physical exam, particularly if you're thinking about FH. And we do see these things. I know in medical school you learn about, I've never seen ARCUS, I've never seen xanthelasma, I've never seen xanthomas. You do see these things, particularly in the FH population. Document the highest LDL cholesterol, ideally off of treatment, although most payers don't require you to take them off of treatment to show that. Show relevant recent labs overall. And I think the one important takeaway for this is about team-based care. So how do you leverage a group of individuals that can help you with this? And in your ambulatory settings, at least for me, how do you leverage clinical pharmacists, medical assistants, nurses, nurse practitioners, physician assistants? And I would argue that there's a lot of benefit to actually consolidating this in one person. Make them your PCSK9 inhibitor expert who helps with the authorization process. Make somebody your sacubitril valsartan expert that helps with the authorization process, only because they can get very familiar with what's required for documentation overall. I will just say that the American Society of Preventive Cardiology has developed a sample uniform prior authorization form and letter just to try and standardize things for you across payers. Not only do we have multiple payers, but we have multiple plans within the payers, and each plan can have its own authorization process. That's gotten much, much better in recent years. The American College of Cardiology has a prior authorization reporting tool that's not unique to PCSK9 inhibitors. And the National Lipid Association has a prior authorization checklist of just helpful tools or tips to go through to be able to help facilitate approval overall. I think this is one of the last slides I would say is focus this attention, because regardless of whether you say, I'm never going to deal with cholesterol in my lifetime, that's probably hard to do, or I'm never going to deal with any of these things in cardiology because I'm not going to cardiology, this is important, and it's a lesson learned for me as many others. So this is actually the Medicare Part D journey that our patients take. In this case, an expensive drug. So if you're on Medicare Part D, you come in and you haven't hit your drug deductible, so you have a high out-of-pocket cost of $600 month one. You then go into the initial coverage phase, where in this case, it's on the order of, let's say, $300 or $330 a month, and then you hit a coverage gap, and the price goes back up. And then at some point, you exceed, it was in 2017, $4,850. I think it just exceeded $5,000, but it's in that order that if you hit more than $5,000 for the out-of-pocket drug spend for Medicare Part D, you then go into catastrophic coverage, where you're only responsible for 5% for the remainder of the year. And this is a challenge, and it sounds crazy, but we're now seeing patients who've had an MI, and they're on a lot of therapies. We're lucky in cardiology, the vast majority of our drugs are generic. But in the endocrine world, the rheumatology world, the pulmonary world, many of these drugs are branded and quite expensive, so my patients tell me. And so we're seeing more and more people hit this catastrophic coverage earlier in the year, but that means they will have had to spend roughly $5,000 out of pocket for their drugs, which I can all but assure you in this community and in my community, most patients don't have the disposable income to do that. They're letting you know they're having a hard time paying their rent with their Social Security and putting food on the table overall. So I raise this issue not to have a great solution for this. As many of you may have seen, Congress has just commissioned a whole group to start looking into this about why we pay 5 times more than Canada and Europe for our drugs, our seniors do. But this is the challenge that all of our seniors are going through. And when they complain about high drug costs, this is reflective or eminent of what we are seeing them have to deal with all the time. So I will just say that there are some support and copay programs that do exist. These largely consolidate in on the commercial patient population and are not as widely available in the Medicare and Medicaid population. Skip through a couple of these. So we go back to the patient case. You prescribe a PCSK9 inhibitor, it's denied. What tactics might you apply? You apply many of the things that were described previously. Ultimately, it's approved. You start them on a PCSK9 inhibitor, follow-up lipid profile 12 weeks later on the PCSK9 inhibitor. Their LDL is down from 101 to 45. And so for this at-risk individual who's had, very high-risk individual, who's had a prior MI and now has had an acute coronary syndrome in the last 12 months, trying to get their LDL cholesterol is particularly down and particularly important. So just a couple of pages of take-home message, and then I want to open up for questions. Statins are the most effective traditional LDL cholesterol lowering therapy and should be used at maximally tolerated intensity in those at highest risk. Numbers 1 through 10, maybe 1 through 7, because there's 7 of them, are statins, 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 highest intensity that's tolerated. Assessment of cardiovascular risk among patients with ASCVD can help determine those most likely to benefit from non-statin therapies. This is that very high risk versus not very high risk group. The currently approved PCSK9 inhibitors, alirocumab and evolocumab, achieve significant reductions in LDL cholesterol when used alone or in particular on background statin therapy. And on that background of statin therapy, they reduce the rates of adverse cardiovascular events in both acute coronary syndrome and stable atherosclerotic cardiovascular disease patients. And the results from Odyssey Outcomes and Fourier fundamentally validate what was called an LDL cholesterol hypothesis or the cholesterol hypothesis. It's no longer a hypothesis, it's proven. Getting people's LDL cholesterol down is associated with significant event reduction, and thus having people have higher levels of LDL cholesterol is associated with an incremental an increase in their risk overall. It's probably not so true anymore. Today, initially, it was about 80% of them were denied. Right now, I have a denial rate of about 11 to 15%, but that's not my problem today. It's not the denial, it's the affordability of the agents overall. While documentation requirements vary among payers, a majority of the denials are due to incomplete documentation, so we bear some responsibility for that. Team-based approach, leveraging other resources, all of these can be helpful, but these people face significant out-of-pocket costs, particularly if they're insured through a government payer, and I would leverage any and all co-payment support programs that you can get your hands on overall. So with that, I want to open it up for Q&A. I will let you know that I went through fellowship, finished fellowship in 2006. It was a pretty boring time in the lipid arena because it was like statins and statins and statins. And not only do we have, obviously, objective data now for ezetimibe, we have the PCSK9 inhibitors, and there are newer therapies that are underfoot, PCSK9 RNA synthesis inhibitors, ATP citrate lyase inhibitors, just published in New England Journal of Medicine this week. So we're beginning to see a dynamic and shifting field in how we might be able to modulate cardiovascular risk through lipid management, and I think it will be more dynamic than when I went through training. So with that, thanks so much for the opportunity. Really appreciate it. And I'm happy to take questions, and I'll try and repeat them as best as possible.
My question is, it looks like both these populations, like in the course that you showed, already on statin therapy, one got PCSK9. I was wondering if PCSK9, maybe it would make sense to test this, but has it ever been tested one-on-one versus statin?
So a head-to-head versus a statin?
Yeah, in terms of LDL and more importantly, cardiovascular events.
Yeah, which is a great question. So the question is, has there ever been essentially a comparison of statins versus PCSK9 inhibitors? And there has been in terms of looking at the magnitude of LDL cholesterol reduction, and highest intensity statin therapies fall even a little bit short of PCSK9 inhibitors in their LDL cholesterol lowering effect. The oral formulation, generic availability will never allow for, I can't imagine, a scenario where they would be used. So in that very small percentage of individuals that are truly statin intolerant, where they're on ezetimibe alone, then in those individuals a PCSK9 inhibitor would be added as largely their workhorse LDL cholesterol lowering agent. And we have no outcomes trials evaluating the scenario you put forward. But the question is, if cost wasn't an issue and you could get by with it, would they achieve comparable magnitudes of event reduction proportional to LDL cholesterol? Probably yes, but I'm speculating. Question.
So I know that there's limited data on this, but what are your thoughts on the ESRD population and the lowering of the LDL-1, whether they fall into those high risks? Because I know CKD3 and 4 do according to these guidelines, and if they do fall into the, in your opinion, the higher risk, then what should we do about them?
Yeah. So I'll actually extrapolate it one step further. The question is about end-stage renal disease. It's been called out in the previous guidelines as a group that may not benefit from intensive LDL cholesterol lowering. Part of that may be that they don't live long enough potentially to derive that benefit. And grouped in that was also heart failure that were due to non-ischemic etiologies in particular, although they didn't actually, in the Corona trial, even break it out that way, and it may be for the same reasons. The data would suggest that this was less of a safety issue and more of a lack of efficacy issue overall. And I think the challenge now for us is, well, what do you do with a person who's got multivessel disease, who has end-stage renal disease? And the guidelines, and we talked about this at ACC 48 hours ago, is there's generally an attitude for most individuals. And the guidelines give latitude in 2018 to say if they have an ischemic etiology and they're increased risk, you should feel comfortable, if you want to, you should feel comfortable initiating the therapy. I tend to, for ischemic cardiomyopathies, for people with end-stage renal disease, and certainly chronic kidney disease because it's a risk modifier, a risk enhancer, I tend to use the therapy overall. There is potential increased susceptibility to some statin-associated muscle symptoms in certain subgroups of individuals, so I watch these individuals very closely. But those of you in the audience may know better than I, but the lifespan of those who hit then the dialysis can be subject to early mortality in that patient population. I don't think having end-stage renal disease as an independent sole factor in someone who otherwise doesn't have clinically evident ASCVD would be an automatic indication for going on intensive statin therapy. Great question.
Compliance is a big deal. So I saw on your slide there's 2 ways to administer, whether it be every 2 weeks or every month. So what is the benefit of doing it every 2 weeks versus just how you do it once a month?
Yeah, so the question was about compliance with PCSK9 inhibitors. When they first came out, they were every 2 weeks. And shortly thereafterwards, evolocumab had a monthly indication, and alirocumab just recently, in the last 6 months, garnered a 300 milligram per month, as opposed to 420 milligrams for evolocumab monthly dosing option. I tend to do a month because it's easier, because people will say, the 15th of the month, or payday, or whatever it is. If they want to do every 2 weeks, payday is a good one. If they want to do once a month, pick a day. My birthday's on the 7th. I'm going to do the 7th every single month overall. I will say there's a little bit of excitement right now about a PCSK9 RNA synthesis inhibitor. The one that's furthest along is inclisiran, which after the first 2 doses, 90 days apart, is dosed every 6 months. And it probably, area under the curve in terms of magnitude of reduction, is about a 45% reduction, only because as time goes on, the effect wanes. But it's that tension between, can we dose them less frequently and still derive some fairly significant LDL cholesterol lowering? So in that situation, the concept of even getting dosed in the clinic twice a year, or giving yourself a dose twice a year, even affords the ultimate in potentially adherence by just saying, we're going to give it to you twice a year and we know what your LDL cholesterol will be. It's a great question, but I think that's the direction we might see, is less frequent dosing down the road, even more so. Not a monoclonal antibody, but an RNA synthesis inhibitor that mucks, that's with an M, mucks up RNA transcription. So,
in those lines, are we any close to the Orion data?
So the Orion data should be coming out soon. I mean, whether it's going to be ESC or AHA, so we're talking about September versus November is when we're expecting data for that. We should see the outcomes trials for bempedoic acid, which is an ATP citrate lyase inhibitor, more definitive data as opposed to just the LDL cholesterol reduction for the Clear Choice large outcomes trial soon. So there's some excitement out there in terms of where we may be going. And I know we're at the top of the hour. I know many of you may have to get to other places. Happy to answer questions for a few more minutes, but it was really a pleasure and an honor, and thanks for the invite.